All right, thanks everybody. Hopefully you're enjoying the session. I have. It's been amazing so far, and we're going to continue on. We're going to start with Dr. Cox to start out this session. When and how to perform an effective concomitant maze procedure, and we'll look forward to this. Dr. Cox.
Thanks, Mark. Yeah, we had to change the schedule a little bit because of technical problems, I think. Well, I'll try to make this short and sweet in terms of how or when and how to perform an effective maze procedure. I'm hoping this thing may not work from here. How about if I point it that way?
Yeah, the green button worked.
Oh, yeah. Okay.
I think.
Yeah, okay, that's good. Yeah. So let's look at when to do a concomitant maze procedure first. This is the distribution of the atrial triggers in patients with paroxysmal AFib. The first thing you need to do when you're trying to figure, when you're ablating AFib in a patient who's having some other index operation, is you have to classify that patient as paroxysmal or something else. I mentioned that in the session this morning. And I'm sorry, but I'm going to repeat a lot of what was said this morning. Because the paroxysmal and non-paroxysmal AFib are treated in an entirely different way. The objective of treating paroxysmal atrial fibrillation is not to ablate atrial fibrillation. It's to isolate as many of the triggers that induce atrial fibrillation as possible, thereby decreasing the likelihood that patients will have more episodes. So this is an accurate, pretty accurate distribution of where the triggers are located. And in paroxysmal atrial fibrillation, it occurs that you will see as surgeons, which is called concomitant paroxysmal AFib. About 70% of the triggers lie within what would be a box in the posterior left atrial wall. About 20% of those are in the posterior left atrial wall. That leaves 50%, evenly distributed more or less between the left pulmonary veins and the right pulmonary veins. And therefore, there's about 25% of them located in the left pulmonary veins, 25 in the right pulmonary veins, 20% in the posterior wall. If you then look at the left atrial appendage, about 10% are located in the left atrial appendage. So let's say this is a patient who has coronary artery disease or aortic valve disease, and you don't want to open the left atrium and do a whole maze procedure. This patient, if you do a box lesion, and there's a nice clamp now, an Encompass clamp to do that with, you go on bypass, you do a box lesion and put a clip on the left atrial appendage, you will decrease that patient's episodes of AFib by 80%. Now, theoretically, or not even theoretically, in reality, that atrium can still fibrillate, but it won't fibrillate because you've removed all these triggers, and 80% of them. So that is an excellent operation for paroxysmal atrial fibrillation, and you can expect about an 80% success rate without opening the left atrium. The non-paroxysmal atrial fibrillations don't have anything to do with triggers. Think about this. If you have somebody who's vulnerable to having AFib and you wanted to take them to a lab and induce it, what would you do? You'd put a catheter in and rapidly pace them, boom, 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 like that. As soon as they go into atrial fib, you'll stop pacing. So in that case, the pacing is the trigger. You stop the trigger, you take it away completely, and they still fibrillate. So it's not the triggers that are making them fibrillate, it's something else. And what that something else is, I'm still getting spam calls, what that something else is these big macro reentrant circuits. Now, these all don't appear at the same time. This is just where they have been mapped and identified in the past. and there are only certain areas they can occur in. But every one of the red circles on there has been documented in the past. And the only thing that's required for it to be atrial fibrillation is 2 of those or more of those simultaneously. Then you've got atrial fibrillation. If only one of them appears, and it's in the right side, you usually have atrial flutter. On the left side, you'll have what's called atrial tachycardia. But if 2 of them occur at one time, it screws your EKG up. And remember that AFib is an ECG diagnosis. It doesn't tell you what's going on. But any patient with atrial fibrillation that's sustained, once it's induced and is being sustained, has 2 or more of these circuits in their atrium simultaneously. Okay, it's no more complex than that. If you do the box lesion and an atrial clip on these patients, you'll get about a 30% success. Now, this is exactly the same operation we just did for paroxysmal, where we got an 80%. So if you ask, should we do a box lesion on everybody? Well, and you can do a box lesion and a clip on everybody, but you won't get the same results if the patients, in the patients between paroxysmal and non-paroxysmal patients. And that's the reason. So the question then, is it worthwhile doing a box lesion and a clip to left atrial appendage if you're doing a coronary bypass operation in a patient who's been in atrial fib for the last 6 months? Well, you know, experienced surgeons would do a maze procedure in those patients, there's no question about it. But if your choice is between doing nothing and doing something, then yes, it would be worth doing it. You'll get 30 or 40% of the patients. That's what you can plan on. But you will not get anything close to 80%. So it's a decision you have to make. So when to perform an effective concomitant maze? If your primary index surgery is either CABG AVR or CABG AVR, those are patients you would not normally open the left atrium, and those are patients who originally we would have done maze procedures in them anyhow. And most surgeons that you'll hear speaking today are experienced arrhythmia surgeons, and they just do a maze. If you have atrial fib, you just do a maze, and it'll get them all. You have to worry about what kind it is. But most surgeons don't do this kind of surgery, or if they do it, they don't do it very often. So the question is, are there some other options? And I think it's reasonable to think that today that it's quite acceptable to do a box lesion plus left atrial appendage occlusion for patients who you otherwise would not open the left atrial appendage. Would not otherwise open the left atrium. Now, there's obviously been a lot of literature to back this up, and both the STS, European Society of Cardiology, and European Society of Cardiothoracic Surgeons guidelines all give a Class 1 level A recommendation for ablating atrial fibrillation at the time of index cardiac surgical procedures. This is a slide from Pat McCarthy's paper that was written a year or so ago, and what it shows is that of patients, if you look across the board for all cardiac surgery, the number of patients, all cardiac surgery being done in patients with atrial fibrillation, less than 25% of them are being operated on. Now, it's less for coronary and aortic valve patients, and it's more for mitral valve patients. But overall, it's less than 25%. It brings up the problem that I think is the biggest problem we have in the whole field today. And I mentioned this morning. Start over on the left-hand side. Lima to the LAD and concomitant AFib ablation. Lima to the LAD is uniformly accepted. It came from the work at the Cleveland Clinic years ago with Fred Loop and Toby and all those guys and Bruce, that published a paper, it's sort of a landmark paper, that said that if you compare patients undergoing coronary bypass surgery who did and did not get limas to the LAD, there's a 10% difference in the 10-year survival rate in those patients. And everybody said, okay, we got to do it. Guidelines picked up on it, and so on. There are several papers that show the same kind of thing with ablating concomitant AFib now when you're doing index procedures for cardiac surgery. I think the best report on it was by Ralph Damiano and our old group in St. Louis, who you, for example, were on the paper, that if you look at because I know how closely these guys followed those patients and how closely mine were followed. And over a 10-year period, if you look at the difference in patients undergoing cardiac surgery at Barnes with and without ablation, there's not a 10% difference, there's a 20% difference in 10-year survival. So think about that. You can impact 10-year survival in coronary and aortic and cardiac surgery patients more by ablating their AF, if they have it, than you can impact it by doing a lima. Nobody would think of doing all bypass grafts using saphenous veins. And you shouldn't think about doing an operation on a patient who has AFib and ignoring the AFib. If you go across that screen, you'll see the impact on the operative mortality is the same, is none. Impact on operative morbidity, there's none. Impact on 10-year survival is an increase of 10% with lima to the LAD, an increase of 20% with concomitant AFib. Guideline recommendations are the same, but the surgical adoption is 99% plus for limas and less than 25% for AF ablation. As a specialty, we've got to deal with this problem, and we need to deal with it very soon, because as soon as the lawyers get a hold of this, a lot of people are going to get in trouble, because this is not coming from outside information or outside recommendations. These are recommendations that tell us the level of surgery and the quality of surgery we should be doing until 2025. And yet, I'm seeing all these patients with AFib, and I'm doing mitral valves and coronaries on them and so forth, and I'm ignoring the AFib. That means those patients are going to, 20% more of those patients are going to die in 10 years. They're not going to let you by with it. So I think that we need to move on this. I think it probably starts with the American Board of Thoracic Surgery changing the requirements. The Residency Review Committee will follow that, and the TSDA will follow that, so that residents are trained properly. But this is a serious problem. What about how to do a concomitant maze? Well, we could maze mitral valve. We could spend a long time on this, but I'm going to spend about 2 minutes on it. In the mid-90s, we switched from an old cut and sew maze 3 procedure to a cryosurgical maze procedure. Everybody in the mid-90s was trying to develop minimally invasive surgery for everything, for valves, for coronaries, for everything. And so I decided we ought to have a minimally invasive maze procedure. But going through the right chest, you can't do all those incisions on the maze. Well, you can do them, but there's almost always a bleeder coming from the circumflex on the lateral aspect of the left atrial appendage. If you take that left atrial appendage off, that's going to bleed, and you can't get there from here. So that's why we switched from making incisions to making linear cryolesions, where we eliminated the bleeding problem. We didn't change the pattern at all. So one of the mistakes, the misconceptions that people have is that the term maze 3 procedure and cut and sew maze 3 procedure are the same. A maze 3 procedure, and even the reported results, includes about half cut and sew and about half cryo-maze procedures. So maze 3 refers to both of those, okay, when you're looking at results. As you know, Ralph, once the radio frequency came out in around 2000 with the devices and so on, Ralph added RF to cryo and made the procedure a lot quicker. And so it's the one that we sort of teach now, but you make the lesions differently, but they're the same electrophysiologic lesions, and that's called the maze 4. But the advantage of it is it's quicker. The way I prefer to do it is to make the incisions. First thing you do is arrest the heart and open the left atrium. You then take a cryo probe that goes from the lower extent of the left atriotomy along the posterior left atrium, curves around partially around the left pulmonary veins. Then you take another, and it creates that lesion you see down on the right lower side. The next step is to take a different cryo probe, bend it differently, so that you can go from the top of the left atriotomy and complete the lesion around the left pulmonary veins. And now, as you see down in the bottom there, you've got a box of the left atrium isolated. That gives you your box from the inside. So if you're going to open the left atrium, there's not any real reason to do an encompass box from the outside. You can. There's nothing wrong with that. But it's about the same time to do it from the inside, and you can see it better. So the next step is to place the cryo lesion out into the left atrial appendage. Now this is equivalent to the lesion that goes from the left superior pulmonary vein into the left atrial appendage, and it prevents conduction across what's called the Coumadin ridge, which gives the cardiologist so much trouble because of reentry. And it lies between the left atrial appendage and the left superior pulmonary vein. So you've got the lesions that you see down on the right lower side after that one. You then place the cryo probe, curve it, place it behind the heart by taking some forceps down at that lower end of the right atriotomy, of the left atriotomy. Pass the probe behind the heart, put it right on the coronary sinus, which you can see, and push towards yourself, pull up towards yourself. So you've got pressure to collapse that coronary sinus and turn the cryo on. What will happen is you'll see an ice ball develop on the inside of the left atrium. Now, once that develops, if you turn that probe off, it's going to disappear. So before you turn the probe off, look down at the right lower there. You want to mark that with a methylene blue, so you know exactly where that cryo lesion is, because you want it to be in exactly the same plane as the mitral line that you're about to put in. And you put that in with a probe from the lower end of the atriotomy down to the mitral valve, and you put it directly across that blue dot. So now you know you've got your coronary sinus lesion in exact alignment with the mitral annulus, which is absolutely critical to the operation. And you're through. I mean, that's it on the left side. Close the atrial appendage up, as we talked about earlier today, and I'll repeat it for people who couldn't see me sitting at the desk. The atrial appendage is like the mouth. When it's open, it's more round or oval. When it's closed, it's a straight line. Same way with the atrial appendage. If you were going to close your mouth, sew your lips together, you would never do it this way. Okay? So you shouldn't close the left atrial appendage this way. What you do is put a couple of Kittners inside the orifice of the left atrial appendage and start doing it like this. There it is. So now you've got the corners, and that's how you close it from the inside. And it, at least in our experience, won't come open. We did the first 300 or so maze procedures. No, we did the second 300 or so maze procedures, the cryo maze procedure. We always closed it from the inside like this. I've had one that caused a problem. That's the point, once you finish the left atrial lesions, that's the point at which you put the mitral valve in or to repair the mitral valve or do whatever you're going to do to the mitral valve after you've done all these lesions. Once you've done the mitral valve, you go to the right side and you make a right lateral 80. You can do this through purse string sutures, but nobody does that much anymore. But on the right side, if you place this lesion in, my criticism of the way most people place this right atriotomy is they put it too high and too vertical. The fibers of the right atrium that are in this area are diagonal. They go diagonal. And I don't like crossing those perpendicular or something. So I always put this, the proximal end of this lesion, of this atriotomy on the right side, about 2/3 of the way down between the SVC and IVC. Take it diagonally over to the edge of the AV groove and stop. Because if you can't put it all the way down to the tricuspid valve yet. What you then do is put a curved cryoprobe in at the distal end of the atriotomy, curve it, take it down to across the tricuspid valve, 2 minutes, stop. That's what we call the T lesion. Then you need to make a lesion between the SVC and the IVC, and the easiest way to do that is just either take a clamp or you can take a cryoprobe, go from the proximal end of the incision up to the SVC, proximal end of the incision down to the IVC, and then the only place that reentry can occur in the right atrium once these two lesions are in, the only place that reentry can occur is around the base of the right atrial appendage. Now, Pat and I approach this differently because he makes the point that I've never seen reentry around the right atrial appendage after a maze procedure, and I agree, I haven't either. But I still prefer to put a lesion there just in case it might happen sometime. And you just put a lesion from the end of the distal end of the right atriotomy up to right atrial appendage. He leaves this out, doesn't matter, doesn't seem to matter much. At most, it's probably 4 or 5%. So that one's optional. But notice that there's an area between that last lesion that we put on and the SVC lesion. That's what I call a no-touch area. Don't pick it up with forceps. Don't press on it with anything. Don't put clamps on it, for God's sake. Don't retract it hard. Leave it alone. Don't touch it, because that whole area can be involved in generating normal sinus rhythm. So you protect that as if it were your eyeball. That's a no-touch reason. Don't ever pick any tissue up there with forceps. You'll pay the price. And so then you close the right atriotomy and you're finished on the right side. So it's not that complex an operation if you take it step at a time. Now I'm going to try to show you this. I don't know if, let's see, is there a cursor up there?
Let me
Mark?
check. Oh, it's gone.
Oh yeah, there it is. This is just an animation. This is an animation of a maze 4. I just showed you a maze 3. But this is an animation of a maze 4. So here you put your clamping the right pulmonary veins from outside the heart to isolate them. And what most people do is they then check the pulmonary veins. Now this is fine because it's before you've arrested the heart. You're on bypass, but you haven't arrested the heart. Then move the heart over and go around the left pulmonary veins. And notice the lesion's well up onto the atrial appendage. And then you check to be sure those two are isolated. And it gets a little more difficult to follow here, but you then do a closure of the left atrial appendage. Lesion from the left superior pulmonary vein, left atrial appendage to the left superior pulmonary vein, across Concomitant ridge, and then close the atrial appendage. We usually use a clip. And then you've done all that from the outside. So when you open the left atrium, you got less to do. The first thing you do is you put the roof lesion in from the left atriotomy to the left superior pulmonary vein, and then from the lower end of the atriotomy to the left inferior pulmonary vein. That gives you your box lesion. You then identify the coronary sinus, whether the watershed area, and then you put your cryoprobe outside the heart, push up on it, so you see this ice ball come inside the left atrium, mark the ice ball, and then put your cryoprobe from the lower atriotomy across that blue dot down to the mitral annulus. And you're finished. So there are a variety of ways of creating these lesions, but there are not a lot of lesions there. On the right side, this is the right atriotomy. I'd put it in a little bit different place, but then you go down to the tricuspid annulus with your cryoprobe. You go from the proximal atriotomy up to the SVC, proximal atriotomy down to the IVC. That gives you your intercaval lesion. And you've got one more lesion that I told you about that I put in and Patrick doesn't. That doesn't seem to make much difference, and that's from the distal atriotomy up the atrial appendage. And you're finished. That's it. So that's how you do it. Again, I thank you for inviting me to this conference. David.
That was spectacular. We'll discuss that a little bit later as to how we can incorporate that into our practice and do it actually in more patients. When we compared the Maze 3 to the Maze 4, Sunil Prasad wrote that paper in the late 2000s. The Maze 4 was not as good as the Maze 3, this cut and sew Maze 3. That's probably because you're counting on the RF ablation to be placed correctly, tissues overlap, you may not get full thickness, which we can't test intraoperatively. Is there any future to being able to test our lesions, make sure they're complete?
You know, mapping in the operating room is strange business. I mean, we used to map the first 70 patients or so just because we wanted to be sure that we knew how the activation pattern was after the maze. Mapping systems, even the ones that the cardiologists use in the cath lab, are used primarily as confirmation tools. They're not really mapping atrial fibrillation and ablating it on the basis of the map. They're creating pulmonary vein isolation and testing to be sure whether it's confirming whether or not it's isolated. And so it really, if you think about it, there are two things that have been shown to work for atrial fibrillation. Pulmonary vein isolation, that's including the box lesion, pulmonary vein isolation, and the maze procedure. And you don't need to map for either one of them. They're anatomically based procedures, whether we're doing them or the cardiologists are doing them. You don't need mapping. And we don't use mapping. So mapping is a bit of a misnomer. It's like catheter ablation is a misnomer. They don't ablate they don't ablate atrial fib. They isolate triggers. So, but that's okay. But it's a little bit misleading to think that, you know, you got to have these fancy mapping systems to go in and tell you what to do. You know what you're going to do. And it's basically a confirmation tool.
That's great.